Okay, I'm going to talk to you about a part two of pulmonary cases. And forgive my laryngitis, but I'll try to talk as loud as possible. So I'm going to give you a bunch of cases and you tell me the correct answer. So we're going to cover chronic cough, shortness of breath. A 45-year-old female for 7 years has had dyspnea on exertion, cough, hemoptysis. She's a lifetime non-smoker. She has paniculitis. Her blood work is normal, and her pulmonary function tests show some abnormalities in her total lung capacity, FEV1, and diffusing capacity. And the CT scan shows bullous changes worse at the bases. So your likely diagnosis is what? That is correct. Alpha 1 antitrypsin deficiency. And which allele is most commonly associated with this? Emphysema, found in 3% of Caucasians. It's the Z allele, Pizz. There's about 100,000 in the US, 3 million worldwide. The average delay of diagnosis is 7 years. The mean age of diagnosis is 46. Emphysema in the lower lung is more common. Bronchiectasis can be found, and the diagnosis is measuring the A1A serum level. You should think about this in a young individual, less than 45, with emphysema, a non-smoker or minimal smoker with emphysema, lower lung emphysema, family history of emphysema or liver disease, clinical findings of paniculitis, and unexplained chronic liver disease. And you can find this published in a journal listed there. Now, the second case is a 59-year-old male from Missouri with chronic cough, hemoptysis for 6 weeks. He had a history of MRSA pneumonia and boils and a left lung empyema decortication 3 years ago. And now we find some white calcified stuff surrounded by an area of consolidation. What is your likely diagnosis given this history? It didn't change 3 months later. There you have it. He's still having hemoptysis. So I wonder what he has. Well, he has a Bronco Lift. Now, Bronco Lift is a calcified mediastinal lymph node. The calcium moves around and it can erode into the bronchus. The most common cause is histoplasmosis. Other causes are TB, cocci, crypto, actino, nocardia, and silicosis. Males equal female incidence, 50 years of age, median age, right lung 60%. Cough, chronic hemoptysis, wheezing, lithoptysis, coughing up stones, and bronchoesophageal fistula. Rigid bronch removes it successfully 20% of the time. Surgical resection is required like our patient, and he was cured after surgery. Now, third case, 58-year-old male with emphysema, 80-pack-year tobacco history, frequent hemoptysis, PPD positive, took INH 12 years ago for 9 months. Based on the CAT scan appearance, what is your likely diagnosis? Answer is an aspergilloma. So, one study showed 14 patients with aspergilloma, oral itraconazole for 7 months, 2 cured, 8 improved, 2 worsened, and 2 neither improved or stabilized. Amazingly, this was published in a dermatology journal. I'm not sure why. Another journal, spontaneous resolution of aspergilloma occurs in fewer than 10% of patients. Progression to chronic cavitary pulmonary aspergillosis is common. Embolization is one treatment, surgery, antifungals, the azoles, and our patient had surgical resection and was cured. Another article claimed up to 70% success rate after 1 to 6 months, which was an outlier. Okay, how about this one? Asthma complication, a 30-year-old female with asthma, chronic cough, wheezing, brown flecks in sputum, IgE is elevated, eosinophilia is noted, and bronchiectasis is present. What is your likely diagnosis? ABPA, allergic bronchopulmonary aspergillosis. Now remember, there's four forms of aspergillosis. ABPA, the asthma allergic form, the aspergilloma, which was the last case, then the chronic necrotizing aspergillosis and the usual COPD, chronic steroids, and then the leukemia bone marrow angioinvasive aspergillosis. Now, the diagnostic criteria for ABPA is asthma, eosinophilia, IgE elevated, positive aspergillus antigen test. Your classification can be 1 through 5, with 5 being end stage. Typical treatment is Itravori with prednisone, sometimes just prednisone. All right, another case, a 35-year-old male from Vietnam, has a history of TB, and he dies with massive hemoptysis and chokes on his own blood. And prior to his death, they found this blood vessel abnormality in his cavity. What's the name of that abnormality? Any guess? Okay. It is called Rasmussen's aneurysm, and it can occur with a TB cavity. We had a case of a mold cavity, and the man died of asphyxiation on blood, massive hemoptysis, as it erodes into the pulmonary artery. Okay, thoracic surgery complication. 73-year-old right upper lobe squamous cell carcinoma undergoes a right pneumonectomy, mediastinal lymphadenectomy, history of emphysema. He's now post-op, 1 week, short of breath, cough, sub-Q air, right chest, white count 27, Pseudomonas growing from pleural fluid. Here's his pre-op lung cancer. Here's his post-op case. What do you think? He has a bronchopleural fistula with a hydropneumothorax. What is the treatment of a bronchopleural fistula? Close it. How do you close it? Well, in this case, they used a omental flap and closed the bronchopleural fistula. So there you have that case. Now, bronchopleural fistulas occur in 1.5 to 4.5 cases. Mortality is extremely high, 30 to 80%. The risk factors are right-sided procedures, large diameter bronchial stump, residual tumor, concurrent radiation or chemo, older age over 60, poor wound healing, and you can read about this in the journals cited there. Now, for post-pneumonectomy empyema, 5% incidence. You can break it down into early, within 2 weeks post-op, to 3 months, frequently associated with a bronchopleural fistula. Late, over 3 months, is hematogenous, and the bugs are usually Pseudomonas, Staph aureus most common, polymicrobial in 50%. Yes, if they leave more than 2 centimeters of a stump, secretions pool, and then we get a bronchopleural fistula. Thank you. Now, for post-pneumonectomy pulmonary edema, which basically what happens is your patient has a pneumonectomy, should have had a easy recovery, and they die on the vent in a ARDS picture. How do you prevent it? What is happening? It's not an infection. Well, it occurs in 2 to 5% of pneumonectomies, 3 times more likely on the right than the left, and respiratory distress, hypoxia within 72 hours of surgery. Mortality is 50%. One of our 3 surgeons gives all of his pneumonectomy cases a dose of solumedrol, and he has no cases of this. The other 2 do not do that, and they do have some cases. The problem is you can't predict who needs it and who doesn't, so you're over-treating people. The theory, in my opinion, is a genetic polymorphism to the healing of a trauma of a pneumonectomy allows for an ARDS picture. This is published in Annals of Surgery. Another theory was high oxygen concentration, single lung ventilation, ischemia, reperfusion injury to the other lung. and that was published in 2000. Okay, how about a 50 to 70-year-old female, chronic cough for years, occasional mopsis, may be acquired from your shower head or your water heater. What does she have? With tree and bud nodules. Sometimes it cavitates and gets really bad. It usually likes the right middle lobe lingular area, and the bug is Mycobacterium avium complex, and the syndrome is called Lady Windermere syndrome after the Oscar Wilde play, and it usually requires combination antibiotics. Now, what about the same lady now is 70? She's had MAI for 10 years. She has a recurrent cough, achalasia, acid reflux. She has a pattern that looks like MAI with bronchial wall thickening, bronchiectasis, nodules, and the AFB is growing in 3 days. So this is a rapidly growing mycobacterium with Mycobacterium abscessus leading the charge. And then the body habitus of a woman who gets Lady Windermere syndrome is what? Tall and thin, not short and plump, and there may be a genetic association to that. So for rapidly growing Mycobacterium cases, MD Anderson reported a series, abscessus dominated. Abscessus was mostly in the lung and most resistant. Mucogenicum was more central line, and if you remove the central line with those kind of infections, it helps to cure the infection. And that was published in 2007. How about this case? An ALL patient, bone marrow transplant, graft versus host disease, not complying too well with his meds, and he's got asthma, hypoxia, sinusitis, bronchiectasis, bronchitis, and there's his sinusitis, and there is his bronchiectasis. So what bug loves to follow bronchiectasis and chronically colonize the lungs? That would make you acutely sick. It's Pseudomonas. So he grows multi-drug resistant Pseudomonas, and it was treated with inhaled colistin. He got azithromycin because it prevents the mucoid virulent strain from growing, and he did fine. And of course, he was also infected with a respiratory virus. Now, what are the 3 Hottub associated infections? 1 is skin, 2 are lung. So the skin one, of course, is Pseudomonas folliculitis. The 2 lung ones are, this one makes you real sick, puts you on the ventilator, direct fluorescent antibody positive charcoal yeast extract growing organism. So that's Legionella. The urine antigen shows up late and may stay positive for 90 days, and that can also be used. Legionella is usually not found in your respiratory viral panels, so you have to keep that in mind. Now, what if someone gets out of a hot tub after 24 hours or before 24 hours and they have ground glass pneumonia and hypoxia? What would you say the likely diagnosis is? It's hot tub or sauna pneumonia, and what's the bug? Mycobacterium avium complex, and what's the clinical diagnosis? Hypersensitivity pneumonitis, which you can get from baling hay to cutting sugar cane to sorting coffee to inhaling aspergillus, histoplasmosis, and Mycobacterium avium complex. And usually the treatment is steroids. How about a 20-year-old female with ground glass pneumonia, cough for 2 weeks, IgM hemolytic anemia, bullous meningitis, erythema multiforme? So she has mycoplasma pneumonia with a centrilobular kind of ground glass nodularity, which can occur with viruses and atypical pneumonia. Now, which atypical pneumonia have I not mentioned, and it's associated with adult onset asthma? So we did Legionella, we did mycoplasma. What do you think is left? It's chlamydia pneumonia, but it's been renamed. What's the new name? chlamydia file pneumonia, okay? Adult onset. And remember, the bronchospasm is key there. Now, what drugs do you like to use for the atypicals? Quinolones, macrolides, doxy, and then with bad legionella, you can combine rifampin. Some people say Levaquin's better than azithro. Others say they're equal. Mycoplasma, some people like macrolides the best. Some say it doesn't matter. Chlamydia, some say doxy's always the best. Some say it doesn't matter. But these are the three choices. Now, all three of these drugs have what in common? They get intracellular, they have good alveolar macrophage, epithelial lining fluid levels. Now, what causes a chronic pneumonia for more than 30 days with hepatosplenomegaly and Horder's spots, which are red macules on your body? And most people have no idea until we go into the social history and we find out their pet was this. So they have psittacosis, chlamydia psittaceae, right? Okay. Now, what about this case? Four men playing poker in the kitchen, cats giving birth in the corner of the room, all get pneumonia. One has culture negative endocarditis a month later. It's associated with outbreaks with sheep giving birth, and it's on our bioterrorism list. So this must be Coxiella burnetii, which can mimic psittacosis with the chronic pneumonia, the splenomegaly, and you want to think about sheep, cats giving birth with the placenta coming out in the plume of Coxiella. And then what causes such a severe cough? The kid has conjunctival hemorrhage and the adult breaks a rib from coughing so severely. What would do that? Bordetella pertussis, correct. Okay, so remember that, the ground glass pneumonia. Of course, it's on the increase and it can be found in the older population. They claim your adult acellular DPT, acellular pertussis vaccine only lasts 3 years. However, nobody says get vaccinated every 3 years, but just remember that's not a great vaccine for long-term protection. And remember, it's on the increase. Now let's do a cousin of Bordetella pertussis. What's the cause of kennel cough, which makes your dog cough and sick? It's called kennel cough, as you can see. The dog may die of it, and there's the lungs. So which Bordetella is that? Vaccine preventable, occasionally gets into humans. So that's bronchoseptica. Very good. How about this gentleman at Moffitt had fever of unknown origin. He's 80 years old, lymphoma, got Campath. He almost died and was going to go to hospice, and the steroids pulled him out of that death spiral. But we still didn't have a diagnosis. So now he's better, but now his right arm is swelling. So they think, oh, his lymphoma's back. Let's get a PET scan. The PET scan shows little millet seeds all over his lungs. It shows hilar uptake and axillary uptake in that right arm. The right arm is all hot from the elbow to the wrist, and the MRI shows he's got pus from his elbow to his wrist. And then, of course, he's a little confused, so they MRI his brain, and he has millet seeds in his brain. So what does he have? Reactivated tuberculosis that disseminated. And what do you think caused it? The Campath. Now, interesting, Campath knocks out B lymphocytes, but those are still important in the granuloma formation and maintenance. So the classic drugs, of course, are the anti-TNFs dissolving your granuloma that was in his body for 50 years, and then it reactivated. So this is sort of the mechanism of how that happens. Now, with the anti-TNFs, it usually occurs in the first 90, 180 days. Some drugs are worse than others, as you can see in this slide. Now, the number one bug to give you this reactivation syndrome, of course, is TB. Notice nontuberculous mycobacterium is on the list, as well as a bunch of fungi and bacteria. And then all these drugs potentially can reactivate dormant things, whether it's PML or TB, etc. depending on the mechanism. All right. Now, this person has leukemia, neutropenia, pleuritic chest pain, and they have a wedge infarct, which mimics pulmonary embolism. And then a week later, it starts to round up, and it tends to have a air crescent sign 10 to 15% of the time. And it has a halo of ground glass. And if you treat it and follow it, sometimes it will cavitate. And it takes you on average 3 months, and this is the 3 month later CAT scan left with a tiny hole. If you cut it out, it looks like a big white dead tissue. And if you look closely, the artery is full of the organism. And then if you look even closer, it has 45-degree branching with septation. And if it disseminates, one of the most dangerous places to go is the brain, which causes a stroke. And you can also get it by minor trauma, as the next gentleman showed with neutropenia. And it continued to grow despite all of our efforts, and he ultimately required a below-knee amputation. So we are obviously talking about aspergillus. So it can present in your lung, your sinuses, your brain, or your skin. Now, what's interesting, radiographically, 95% of the time, it's a 1 centimeter lesion nodule. And then the other ones, like the halos, the wedge, the consolidation, the cavity, the air crescent, are less likely. The good news is if they have a ground glass halo and cavitation, they have a survival advantage. And it's almost always in the heme, the bone marrow patients, the solid organ, and some COPD patients, and rarely HIV. And AML is much more likely than multiple myeloma, Hodgkin's, non-Hodgkin's, etc. And the locations are lung dominating and the others less likely. And of course, why is voriconazole the drug of choice now? Because of that article that showed a survival advantage over the old mainstay drug Ampho-B. Okay, another fungus to keep in mind. A 40-year-old leukemic, 21 days neutropenia, who's on cefpine, vancomycin, sub-Q nodules. The infection started on his 5th toe with cellulitis and is getting black necrotic necrosis, and he has 1 to 2 centimeter lung nodules. What do you think the likely culprit is? The answer is, it is Fusarium, and there is your sub-Q nodules all over the body. They're much bigger than Candida, which is about a half a centimeter to 1 centimeter. These can get up to 2 centimeters. If you biopsy it, you got to get into the sub-Q. Notice it has 45-degree branching, but it tends to have ballooning hyphae. It's a cluster of bananas in its fusiform, hence the name Fusarium. It loves to get in through toes, especially after minor trauma, bumping the toe, cutting the toenail. You may see lymphangitic spread. You may see onychomycosis associated with it. It may occur between the toes. And then, of course, when it disseminates, it can go to all organs of your body, including your brain. This lady fell in the parking lot while neutropenic and wound up getting chronic wound infection in the knees. This is the one case we had. Actually, the entry point was the gums, which was very unusual. Notice the nodules are evenly spaced all over the lungs like a septic emboli hematogenous spread, and they don't get bigger usually than 1 to 2 centimeters. Notice the ballooning hyphae. So, in summary, sub-Q nodules, deep biopsy required, toenail removal with culture, ballooning septate hyphae, cluster of bananas, combo voriposa, crescemba plus ambisome.
And more likely to be associated with complication.
And thank you very much. Of all the molds, Fusarium, followed by Cetosporium, is more likely to have a positive blood culture, unlike Aspergillus or the Zygomyces. Great point, should be mentioned. Okay, and obviously this case was published that had a toe infection spread to his brain, and ultimately, what do you think led to his recovery? The answer is the white cells Yes, the ID consult helped, and the white cells coming up was key, okay? All right, the third important mold. A 55-year-old male, bone marrow transplant, chronic graft versus host disease, chronic VFen because on steroids, ferritin 4,000, cough, pleuritic chest pain, shortness of breath. CAT scan shows not the halo sign of aspergillosis, but the reverse halo sign. What do we think that is? The answer is the zygomyces, the mucor kind of ones. Notice how big these are. They're very wedge, and if you watch them within a week or so, there's the reverse halo with the ground glass in the middle as opposed to the outside. This patient, baseline clean as a whistle, now has pleuritic chest pain, a high ferritin on VFen, neutropenic. Now it's starting to form in its early phases, and a couple weeks later, bingo, it has the reverse halo sign, large infarct with the ground glass in the middle. So you want to think about this, of course, in ketoacidosis, but that's mostly sinus. Steroid use, iron overload, it requires exogenous iron to grow. Medications, VFen, by the way, desferoxamine feeds it iron. So they tried a clinical trial of XJade because it starves it of iron, but unfortunately it did not help improve prognosis. So remember the large wedge, the reverse halo, and ambisome plus an azole, posa, Cresemba. And then XJ didn't work, but GM-CSF may help. And then last resort, add gamma interferon. Of course, we're aware of the diabetic ketoacidosis, mucor, with the moose antler, non-septated, hyposeptated, 90-degree branching ribbon-like, and then wide local resection required. And that was your case, so thank you, Dr. Tony. Pulmonary zygomycosis, all of those are re-mentioned there. Now, what's the fourth mold that affects neutropenic? And it may have a higher mortality than all those three I mentioned. This gentleman died of it ultimately. Disseminated black necrotic lesion on his scalp, a nodule in the lung, 1 to 2 centimeters. And the answer is Cedosporium. And which species of Cedosporium is the worst of all? And the answer is prolificans. Apiospermia may be a little bit more responsive, and it's resistant to the echinocandins. It's resistant to the ambisome AFOB, and Vori, Posa, Cresemba would be your only real choice for that. Now, since we're talking about nodular pneumonia, usually this is not a neutropenic, but someone on chronic steroids, it looks like a big old mass. And when you biopsy it, you may see sulfur granules, gram-positive filamentous rod, modified acid-fast positive, so that must be what? Nocardia, okay? And it's chronic steroids, T-cell immunosuppression, and then combo therapy for 6 to 12 months is usually indicated. Now, what if we have a cavitary pneumonia? The modified acid-fast bacilli stain is positive. The lab says this is not nocardia, and on your social history, the patient was exposed to a baby horse, and now they have a cavitary pneumonia. We see this in AIDS patients and leukemia. So this would be Rhodococcus equi, rhodococcal pneumonia, treated with antibiotics. Now, what if you have a Hodgkin's patient with cough, shortness of breath, and it all occurred during tapering steroids? So baseline, the scans look nice. Now it's ground glass. Now the bronchoscopy lavage shows silver-shaped, or silver stain shows cup-shaped organisms. So this must be which bug? PCP. And what is the key? Tapering steroids is the key. Higher mortality than AIDS patients. You want to think about it in all the lymphocytic leukemia, lymphoma patients. How about a 49-year-old patient, leukemic, pancytopenia, progressively short of breath, dry cough, progressive hypoxia. Baseline looks okay. Now we have obvious ground glass, geometric, a mosaic kind of pattern. And the deeper the bronchos, the more pink and red it looks. So this must be diffuse alveolar hemorrhage, and the key is get them on Solumedrol high dose ASAP, or they won't survive very long. How about this case? A CLL patient with fever, cough, progressive short of breath. This is the baseline. 2 weeks later, the bronch is negative. It's getting worse, and now it's really bad, and he's going on respiratory failure. Same different patient, same problem. Starts out like this. Now we're like this. Your next step is open lung biopsy, and of course you find this. So what do you think that pathology is demonstrating? The answer is cryptogenic organized pneumonia, old name bronchiolitis obliterans organized pneumonia. In transplant patients, they have another term, bronchiolitis obliterans, which tends to be less steroid responsive, and the steroids are necessary. Some people say for mild COP, you can think of azithromycin and and giving them an inhaled steroid is one of the possibilities for mild cases. Okay, this guy has paraflu, and he's dying of paraflu, and ribavirin's not working, steroids aren't helping, and nothing is helping. So what do you think you could do based on your knowledge of basic science? So you give him alpha interferon, and the guy completely recovers. You publish your case, and here's his follow-up CAT scan. Same guy, still immune suppressed, shows up several weeks later, and what do you think likes to follow paraflu pneumonia? Aspergillus and molds. Finally, the last case, the lab calls us because this person on chronic steroids with pneumonia has something crawling all over the auger plate with a pearl necklace, and they're worried because it crawled off the auger and maybe onto their table. And when they look under the microscope, they find this creature, which is Strongyloides, and what bug likes to get into the blood as it piggybacks on it as it migrates from your stool to your blood? The answer is E. coli, as this classic board question case illustrates. You may see the organism. Now, when it decides to migrate, it can look like this, which is hard to tell what it is because it's very hemorrhagic. On the left, on the right, it's called what? Larva curans, okay? Larva curans. It tends to go in a straight line, whereas cutaneous larva migrans zigzags. So remember, it can move 5 to 15 centimeters per hour, disseminated strongy. Okay, last case. This lady got a mosquito bite right above her eye. A month later, it's still swollen. So they get a CAT scan. Yep, there's a subQ nodule. Let's cut it out. And what do you think we find? A parasite. In fact, what happened was the mosquito bit the dog, sucked up a parasite, and then bit the person, caused subQ nodule. So what is the name of that parasite? It is the dog heartworm, Dirofilaria emetis. It either presents as a subQ nodule, or if it makes through your systemic circulation, lands in the lung, presents as a coin lesion, pulmonary nodule, PET scan positive. Cut it out, and of course you find a worm in there and not a cancer. And sometimes the worm may even be mummified, as this case illustrates. Thank you for your attention on these cases.